Good afternoon. Why don't we go ahead and get started? It's a pleasure for me today to introduce Jason Koffenbach to you. Jason is an assistant professor of medicine in the Division of Rheumatology. He has actually a very easy history in terms of his academic development to recall because he's only been at two places, the University of Iowa and the University of Colorado. He received his BS degree from the University of Iowa in integrative physiology and then went on to get an MD degree at the University of Iowa. We were fortunate to recruit him here to our residency program. He completed the residency and fellowship program here at CU and then stayed on faculty in the Division of Rheumatology. Jason has focused his career on being an outstanding clinician educator, and he has recently taken over the leadership of the Rheumatology Fellowship from Sterling West, who has done an outstanding job in developing the fellows and developing the educational programs within the Rheumatology Fellowship. Jason is proud to take on the mantle of that leadership and has done a great job with the fellows over the past year and is thinking about novel ways to educate the fellows and develop opportunities for them in terms of their clinical development as well as their research development. Jason's published a number of review articles in rheumatoid arthritis as well as in vasculitis, and today is going to talk about his thoughts about ANCA-related vasculitides.
All right. Well, thank you for the introduction. Thanks to the internal medicine department for inviting me to speak today. I want to go over ANCA vasculitis, and I think this is a topic that's of interest to me, one, because we see a lot of cases of it, but I also think it's of interest because the cases that we'll go through today are largely admitted through the hospital and taken care of by a lot of the house staff. Hopefully, maybe even some of you have seen some of these patients as they've come in. So I think it's informative not just for rheumatologists, but for primary care, for nephrologists, pulmonary, ENT. So we're going to really try to run the gamut because I think this is something that applies and is applicable to house staff and medicine in general. So I don't have any disclosures related to the content of this talk. And the learning objectives that we're going to go through, we're going to focus mainly on granulomatosis with polyarteritis, or GPA. This was formerly called Wegener's, and then microscopic polyarteritis. The third kind of arm of the ANCA vasculitides, Scherk-Strauss, or what's now called eGPA, or eosinophilic GPA. We're not going to cover because that's really a kind of a different clinical animal, and a separate talk would be really needed for that. We're going to go through a couple of common mimickers of ANCA vasculitis, and then finally we're going to spend most of the time on emerging data on treatment options. So we're going to begin at the bedside. So this first case is a 32-year-old man who's admitted to the hospital with new onset shortness of breath. The past medical history is mild proteinuria, and he's followed by an outside nephrologist. He has a family history of FSGS, but no personal history of known renal disease. And when he comes in, he complains about 2 weeks of just general malaise, arthralgias, and a scleral injection for about the past 2 weeks. He was hypoxic on admit, and he had chest x-ray that we'll show next that showed bilateral infiltrates, and he was started on treatment for community-acquired pneumonia by the medicine team. Unfortunately, about 4 days into his treatment, though, his oxygen requirements climbed to about 8 liters, and he was actually transferred to the MICU, and you can see on the picture here, he has bilateral alveolar infiltrates. And so at that time, the data that the medicine team on the ICU service had was that he had a creatinine of 1.2. This is really near his baseline. He's a large gentleman. It was thought to be an appropriate creatinine for his size. He had a normal CBC. He had normal ESR, but he had a CRP that was about 4 times the upper limit of normal, and he had a BNP level that was at 11. He had a multitude of infectious studies done through blood testing that were all negative to date. And then he had serologic data, but not unsurprisingly, they're still pending at the time of transfer. He had complement levels that were checked and that were actually normal. And so upon transfer to the ICU, a procedure was performed, right? So he was on 8 liters of oxygen, and he subsequently had to be intubated because of his work of breathing. And he had a bronchoscopy performed, and he had increasing hematocrits across serial aliquots that was consistent with the diagnosis of DAH, or diffuse alveolar hemorrhage. And so the next day he was still intubated, and some of his lab tests came back at that time, and he had a markedly positive c-ANCA and a PR3 antibody. And so at that time there was consideration about what to do next by the primary team. And some of the considerations that were listed in the notes were to treat with methotrexate, to pursue either a renal biopsy or potentially a lung biopsy, to start empiric treatment with steroids and cyclophosphamide, and to get rheumatology involved. And so thankfully, I'm dependent on you guys calling me so I can keep my job, so we were called. But also, I think that we're going to go through about, why starting empiric treatment with steroids, starting empiric treatment with steroids and cyclophosphamide was the right answer, and we'll kind of go through some of the data for that. So just to put this in a bigger context, so the ANCA vasculitides are really a small vessel vasculitis. And so if you're lumping it in the family of larger vasculitides, we're talking mainly about this area right here that includes MPA, what was previously called Wegener's, or GPA, and Sturge-Strauss. Those are small vessel vasculitides that really span from the small artery to the postcapillary venule. And so that's important because the manifestations that we see with ANCA-associated vasculitis are really dictated by the size of vessel involvement. So things like palpopurpura, glomerulonephritis, pulmonary capillaritis leading to diffuse alveolar hemorrhage, those are things that you would expect to see with a small vessel vasculitis, whereas things like large vessel involvement of the subclavian and loss of pulses are things that you might expect to see with Takayasu's or a giant cell arteritis. Within that group of small vessel vasculitis, there's many different conditions that can be the cause of it. The ANCA-associated vasculitides are considered to be pauci-immune on histology, right? So I think a lot of us have learned that when you get a kidney biopsy on somebody with a GN, then what we're looking for in the report is pauci-immune. And what that means is that in contrast to things like lupus-related nephritis, we don't see deposits of, or at least large deposits of immunoglobulin and complement in patients with an ANCA-associated vasculitides, in contrast to what you would see with lupus. What's important is, though, that doesn't mean the antibody is not important, and it doesn't mean that it's not pathogenic. In contrast, there's actually been in vitro and in vivo studies that have showed that antibody directly binding to neutrophils can activate neutrophils, and these antibodies may even be able to bind to endothelial cell and allow for entry of neutrophils into the vessel wall, contributing to the pathology that we see with vasculitis. So why do we lump these together into one family? And so there's some things that do tie these conditions together, and so they do have some overlapping clinical features. At least in the case of GPA and MPA, they have a similar treatment approach, and in fact, really, most of the randomized controlled trials that have been done over the past decade have used combined cohorts with both of these conditions to study drug regimens. And then obviously, a large percentage of these individuals can be have ANCA-related antibody reactivity. But if we lump them all together, we run the risk of these conditions getting lost in the shuffle, like Jan Brady here, and we would really lose a little bit of information about them. And so it is important to realize that they are separate entities, and in fact, genetic association studies really show that there's actually different genetic associations that drive these clinical manifestations. And I think it's important clinically as well, not just for research purposes, but because the risk of relapse is really markedly different in somebody that has GPA versus MPA. And that's important because it may influence how long we keep somebody on medicine, and certainly when you talk to a patient, you can provide them with better prognostic information if you make that distinction. So this is a busy slide, but again, we're going to focus for the remainder of the talk on GPA and MPA. And I'll try to highlight just the important parts here with these red boxes. So again, GPA is, by definition, it's a granulomatous arteritis. And so it turns out that ear, nose, and throat and ocular involvement are predominantly driven by granulomatous manifestations. So hence, you see a large prevalence of these conditions in GPA as compared to microscopic polyangiitis. In contrast, renal disease is kind of synonymous with microscopic polyangiitis, and so we see very, very high rates in that condition. We're not going to talk much about eGPA. This would be actually the last slide that we cover of it. But eGPA is, or Churg-Strauss, is really predominated by allergic type symptoms. So about 70% of folks actually present with allergic rhinitis that precedes by many years the diagnosis of eGPA. And what I thought was interesting is that if you look at those individuals that are diagnosed with Churg-Strauss that are ANCA positive versus ANCA negative, they have very different features. And so what I highlighted here is that the ANCA positive individuals have much higher rates of kidney involvement and peripheral nervous system involvement, in other words, vasculitic manifestations, than those that are ANCA negative within that class. In contrast, lung involvement and cardiac involvement, which is more tissue infiltration with eosinophils, have much higher rates of ANCA negativity. And so the clinical manifestations within eGPA kind of differ based on whether the antibody is positive or negative. Again, this is just another slide kind of showing that similar concept. It's a spectrum of involvement in terms of clinical manifestations, but on the end of GPA involvement, you have higher rates of c-ANCA antibody reactivity and more necrotizing and granulomatous manifestations and a higher rate of relapse. In terms of the actual antibodies that we see, probably in about up to 90 to 95% of those with systemic GPA will be positive for this c-ANCA antibody, and that's an antibody titer, or rather an antibody pattern that's seen on immunofluorescence that I'll show on a slide ahead. And then in contrast, if you have limited Wegener's or limited GPA, and that's confined to the sinuses, ears, nose, throat area, your prevalence is much lower. And so that's important when you're trying to diagnose that condition, because a negative antibody certainly does not rule out the disease. This is a study done by Leonaki in 2012, and I think, again, it's just another pictorial example that clinical features really differ by your antibody status. And so if you had antibody reactivity against the PR3 antigen, which again is seen more commonly with GPA or Wegener's, you have much higher rates of things on this end of the spectrum, which tend to be ear, nose, and throat involvement. Whereas if you're talking about individuals with renal limited disease, they have much higher prevalence of the PR3 antigen reactivity. Knowing antigen or antibody status is important not only just for clinical manifestations, but it's important to prognosticate about future course. And so this was similar in the same paper by Leonaki, and he showed that rates of subsequent relapse were much, much higher. So this is on this line of the graph, this is relapse-free survival. So those that had the PR3 antigen reactivity were much more likely to have relapse than MPO antibody positivity. And what he did that I think was interesting in that study was that even if you make a clinical diagnosis, you say that this individual has GPA, which we know is a higher rate of relapse than MPA, even within that clinical diagnostic category, it mattered which antibody you had. If you had a PR3 antibody, you had a much higher risk of relapse over time than if you had an MPO antibody. And so again, I think this is important. So these antigens are important not only to help us confirm a diagnosis, but they're important to help us give prognostic information to patients. Knowing the antibody status may not only be important for prognostic information, but it may be important in predicting response to therapy as well. This is a sub-analysis from the RAVE trial, which is the large randomized study of rituximab for induction therapy. And what the results of that final trial showed was that rituximab was non-inferior to cyclophosphamide therapy for induction of ANCA-associated vasculitis. But what this sub-analysis showed was that in the PR3 positive subset, there was actually statistical superiority or benefit of rituximab. And so knowing the antigen status may influence which choice of therapy you choose to use for a particular patient. So in summary, PR3 positivity is associated with granulomatous manifestations. It's associated with an increased risk of relapse and potentially with improved response to rituximab, although this is only from one study thus far. And a classification by antigen reactivity has really allowed for, in research terms, for better genotyping, because it turns out that the genetic associations kind of differ more along antigen status than by clinical diagnostic status. So just a couple words about the test, because I think it's easy to get kind of lost in the details here. So when we talk about a C-ANCA or a P-ANCA antibody, this is an indirect immunofluorescence. And so this is something that, at least in our lab, is a result of somebody actually looking into the microscope and seeing the patterns that you're seeing here. So if you have a pattern that's diffusely staining throughout the cytoplasm, it's termed a C-ANCA reactivity or C-ANCA positive. Whereas if the staining pattern is located around the nuclear structures, it's a peripheral or a P-ANCA antibody positivity. And this is the kind of the screening test, or the first test that we do in individuals that we're concerned for a possible ANCA-associated vasculitis. So just a little bit more, that C-ANCA pattern is typically, about 90% of the time, it is the result of reactivity against the PR3 antigen. So the PR3 antigen is located in the cytoplasm, hence when you have staining of that or antibody reactivity to that, you're seeing it diffusely throughout the cytoplasm. In terms of the peripheral or the P-ANCA pattern, in terms of vasculitis, is typically associated with reactivity against the MPO or the myeloperoxidase antigen. The problem with P-ANCA testing is that you can see a P-ANCA pattern in response to antibody reactivity to multiple other targets. And I listed some of the ones that are here. And I say it's problematic because none of antigen reactivity or antibody reactivity to all of these different targets is not associated with vasculitis. And so seeing a P-ANCA pattern that's not also associated with reactivity against MPO is not highly specific for vasculitis, and so it can result in a false positive test. So in terms of diagnostic utility, if we focus on generalized GPA, so meaning not limited to the ear, nose, throat region, but multiple organs, the sensitivity of C-ANCA is around 90%. So the majority of individuals, the large majority of individuals who have that condition will have the antibody. And the specificity, if you combine a C-ANCA with reactivity against PR3, it approaches 99%. So if we see both of those antibodies, there's very, very few other things that could be driving it other than an ANCA-associated vasculitis. In terms of limited GPA, we kind of alluded to this before, the sensitivity drops significantly. And so someone who has a suspected ANCA-associated vasculitis affecting the middle ear or the sinuses, the absence of the antibody certainly does not rule out the disease. And then finally, in terms of microscopic polyangiitis, the antibody is typically found in about 80% of individuals who have that. And the specificity, if you have both a P-ANCA pattern and an MPO, is fairly decent at 90%. But again, if you have just the P-ANCA antibody without reactivity against MPO, its specificity for vasculitis is actually pretty poor. So what are some things that will kind of raise concern for diagnoses other than a ANCA-associated vasculitis? And so not all ANCAs, again, that doesn't equal vasculitis. And so we can see other things like drug-induced ANCA positivity. And things like PTU, hydralazine, and minocycline are known to induce P-ANCA antibody positivity. Again, they typically don't have reactivity against MPO. Cocaine-induced antibody positivity is also present, and you can invoke a couple of clinical syndromes as well. One of those includes midline hard palate destructive disease. That's, if you see someone with hard palate involvement, that's not common with Wegener's, and so when we see hard palate involvement, we get worried about possible cocaine-induced disease, but also it can invoke, sorry about that, it can also cause these purpuric lesions that you see here at the ear and on the lateral flank, and this were actually pictures from a patient that we saw about 5 years ago by one of our fellows who published this, Corey Ulrich. If you see concordant specificity, so a C-ANCA with a PR3, again, that's the most specific for an ANCA-associated vasculitis. And if we see discordant ANCA patterns along with the antigen specificities, or if you see someone go from a P-ANCA to a C-ANCA pattern, that raises concern that maybe we're seeing drug-induced ANCA positivity rather than a true vasculitis. So just one more slide on, again, just try to differentiate GPA from MPA clinically. You see more granulomatous features by definition with GPA. You can get ear, nose, and throat involvement to a much larger degree with GPA compared to microscopic polyangiitis. The lung is involved relatively equally between these two, although cavitary lesions are more commonly seen with GPA. The kidney is usually involved more commonly with microscopic polyangiitis, as is vasculitic neuropathy. And then finally, CNS disease is relatively rare with both, although if it's seen, it's usually more in context with granulomatous polyarteritis. So how do we arrive at the diagnosis using kind of this information? So it's a clinical diagnosis, and it's supported by serologies and histology. And so a few points are that biopsy is often necessary. So if you have a slam dunk clinical case along with c-ANCA and PR3 antibody reactivity, that might be an exception because of the very high specificity. But we often want a biopsy to confirm the diagnosis, and then also, as we'll see in slides ahead, to rule out some mimickers of ANCA vasculitis. High titer concordant antibody antigen pairs, again, are the most specific, as we feel most comfortable when we see reactivity in both the pattern and against either PR3 or MPO. And that you can potentially see a c-ANCA antibody that doesn't have a concordant PR3, but if you see a p-ANCA and that antibody reactivity and that's it, that really raises our concern that potentially this might be something different than a vasculitis driving it. And certainly in that situation, we'd really want a biopsy to confirm the diagnosis, because again, these medications that we give for ANCA vasculitis are fairly toxic. So back to this case. So this individual had a high pretest probability, and so that's probably the starting point when we want to order these things. So they had a pulmonary renal syndrome, although the renal disease was relatively inactive, but it also had diffuse alveolar hemorrhage without an alternative etiology, elevated inflammatory markers, and then the c-ANCA and the PR3 antibody were markedly positive. And so in this patient, we felt comfortable with the clinical diagnosis of GPA. He was treated with high-dose prednisone and cyclophosphamide. He eventually needed to be transitioned over to rituximab, but he's since done very well. So let's move on to some of those formal treatments. And so the treatments have really advanced because before the advent of cyclophosphamide and prednisone, this was uniformly a fatal disease. So 1-year mortality before the onset of treatment was 82%. Along with the use of prednisone, survival time increased from approximately a median of 5 months to about 1 year. And then with the introduction of cyclophosphamide, we got vast improvements. So about 75% of patients could achieve remission, and about 90% at least experienced some level of clinical improvement. But like everything in life, there was a cost to this. So this is a quote that was from a former NFL football player. See Joel Hirsch in the crowd, so maybe Joel will know who this is. So this is him now. He's holding up a hook 'em horn sign. So he's a former Longhorns. And this is him in his playing days. Joel, you got it? Yeah, it is Earl Campbell. So Earl Campbell was known for a kind of bruising style of football. And here you can see he's using his head as kind of a battling ram. And so unfortunately, this made him a very good football player. But unfortunately for him, at the age of 60, he uses a wheelchair to get around very often because of horrible spinal DJD. And I thought this was kind of an example that, in a similar fashion, cyclophosphamide has been great in terms of prolonging life and improving symptoms, but it came at a very high cost. And so based on some of the data from the initial NIH trials, we know that about half of patients will develop a serious infection, which means either IV antibiotics or an admission. About 60% will become infertile after a year of therapy, and then there's very, very high rates of both bladder hemorrhage and increase in bladder cancer and lymphoma. And so the question that came then is, well, can we do better? Can we give less cyclophosphamide? Are there alternatives to Cytoxan that can have similar benefit but be at a less of a cost? And so some of the initial studies that looked at this compared IV pulse therapy to oral therapy. And as a reminder, IV therapy usually is given about every 2 to 4 weeks. It's given in one large amount, but overall it results in far less milligrams dosing equivalent compared to oral regimen, usually about 2 to 3-fold less. So this was one of the initial studies. This is the DeGroot study that I have referenced down here at number 2. And what it showed is it compared oral to IV cyclophosphamide therapy in the treatment of ANCA vasculitis. And it showed that the time to remission was equivalent between these two strategies. It showed that a reduction in clinical symptoms as measured by an activity score were equivalent between the two strategies. And then dosing with the oral regimen was statistically significantly higher than with IV therapy. And so based upon this, IV therapy is thought to be an acceptable form of treatment compared to oral regimen. It is important to note that subsequent follow-up studies that kind of followed this out longer did show that the IV regimens might result in a higher rate of relapse, but at least as far as inducing remission, it's an equivalent strategy. So what about, a strategy that's even more conservative? And so this is a study that came out in the early 2000s that looked at initially treating with cyclophosphamide, but then transitioning over to a less toxic agent like azathioprine. And so this study compared in a randomized fashion after induction therapy with cyclophosphamide, either continuing cyclophosphamide or transitioning over to azathioprine. And what it showed was that at its 18-month endpoint, these two strategies were relatively equivalent in terms of relapse rate. On the graph on the right is of the glomerular filtration rate, and it showed that you saw similar increases whether you were randomized to the azathioprine maintenance arm or the cyclophosphamide arm. And so initial induction therapy followed by maintenance azathioprine then became kind of a standard way to approach ANCA vasculitis. Since that study, there's been other studies as well, some showing that methotrexate is also a viable alternative compared to azathioprine. In contrast, CellCept is probably, or mycophenolate, is found to be inferior to azathioprine in terms of treatment of ANCA vasculitis. And so that's an agent that still is sometimes used, but usually not before methotrexate or azathioprine for maintenance therapy. What about limited disease? So if you have someone without kidney or renal involvement, it'd be nice to be able to treat them a little bit less aggressively because there's not a vital organ that's immediately at risk. And so this study looked at randomizing patients to no induction therapy with cyclophosphamide to treating with methotrexate initially compared to an arm that got cyclophosphamide. And it showed that you did have an equivalent amount of people reaching remission in a similar time frame. Although at 18 months, those that were randomized to methotrexate did have higher rates of relapse. And so I think this is an option in someone with very mild disease with the caveat that you may spare them some toxicity, but they may have higher risk of subsequent relapse later on. So let's move on to another case and we can kind of see how some of these principles can be applied. So this was a 56-year-old female who has a history of diabetes, hypertension, and a 3-year history of hoarseness and nasal septal perforation. That was first noted in 2010. 2 years later, she had worsening nasal pain and an enlarging perforation of her nasal septum. Later that year, she developed ulcerative lesions on her right flank and her left breast. And in early 2013, when she came to see us, she had, at that point, worsening sinus pain and a skin ulceration that had developed over the left side of the bridge of her nose. So this was the flank lesion that had developed at the end of 2012, and she had a previous biopsy of that area that showed nonspecific granulomatous inflammation, and at that time, she wasn't given any specific therapy. When she saw us, she had a large depression of the bridge of her nose, and then perhaps even more obvious, she had a large communicating ulcer on her face that communicated with the sinuses behind that she was aptly covering up with a Band-Aid. Oops. So at that time, we performed a kind of a larger evaluation to make sure she didn't have disease in any other organs. She didn't have any obvious findings with the CT of the chest. She did, however, have, as expected, largely destructive disease of the nasal septum, of the maxillary sinuses, and of the ethmoid sinuses. She had an ANCA antibody that was negative, and she had a sedimentation rate of 62, or kidney function by blood and urine test looked appropriate. And so at that time, we had a couple of different options that she wanted to talk about. One would be to initiate therapy with prednisone and methotrexate. Another one would be to obtain a biopsy. The third, which she was interested in as soon as was possible from our standpoint, was to have a corrective surgery that she was already talking to an outside ENT doctor about. And then the fourth option was pulse steroids and rituximab. And we opted for a initial sinus biopsy, given concerns about a potential alternative etiology. So before going into a biopsy, it's important to note with head and neck biopsies especially, we often don't see the classic triad. So the triad being necrosis, vasculitis, and granulomas. We only see that triad in about 15% of cases, but it's probably just as important to do a biopsy in some of these cases, especially when the ANCA antibodies are negative, to rule out mimickers. And so some of the mimickers that could be seen are neoplastic diseases like an NK T-cell lymphoma, histiocytic processes, in certain types of infections, mostly fungal and mycobacterial disease, and then foreign material, so cocaine-induced destructive disease. So in this case, she had granulomas, inflammation, necrosis. She didn't have classic vasculitis, but she had a perivascular inflammatory infiltrate. And probably just as importantly, she had extensive testing done for evidence of lymphoma or other signs of malignancy that were negative, and she also had negative cultures as well. So her final diagnosis was ANCA-negative GPA, and then she was placed on steroids and IV Cytoxan, given how aggressive her sinus disease was, followed by maintenance therapy. She's done very, very well. She was able to get that surgery she was asking for. She had a corrective surgery for the large defect alongside her nasal cavity. This is important, though, to do these tests, and I bring this up because this was a case that was taken care of by Kevin Dean, a colleague of mine, who had similarly large ulcerative lesions on the bridge of the nose, and then had a large depression and ulcerative lesion on the hard palate. And again, when we see hard palate lesions, that doesn't usually fit with an ANCA-associated vasculitis. It can be seen in cocaine-induced disease, but it can also be seen in certain types of cancers or invasive fungal infections. And so in this case, there was a biopsy done, and this turned out to be an NK T-cell lymphoma. And again, it's important because this is treated with very aggressive CHOP type chemotherapy agents, which she wouldn't have gotten benefit if she would have gotten treated with some of our medications. Move on to another case. So this is a different patient, 24-year-old female with right-sided hearing loss and ear pain for about a week. She was seen in the emergency room and at that time had a history of rheumatoid arthritis, taken care of by an outside doc with methotrexate and etanercept. And on exam, she had a right TM that was red, and she was diagnosed with otitis media and given some antibiotics. About 3 months later, she saw an outside ENT, and she had remarked upon repeated episodes of middle ear effusions bilaterally. She had now right greater and left-sided hearing loss. It was recommended that she get an MRI and follow up with a further subspecialist, but she didn't have insurance at that time, and for other reasons was kind of lost to follow-up. She came in to the ER again about 11 months later, and at that time had right greater and left ear drainage at this point with worsening hearing loss. And it was kind of noted, there was a more in-depth note, because this is probably the fourth time that she had been in the ER in the last year. And so at that point, they summarized that she had had 3 subsequent ER admissions for progressive symptoms, and they decided to get a CT scan and to consult ENT. And she had middle ear effusions, but then probably most significantly, she had bone involvement or osteitis on the left. And the ENT came and saw her in the ER, and she was provided with Bactrim, recommended follow-up in a week. But again, since she had no insurance, she didn't follow up with anybody. And then she ended up coming in 4 months later with admission for shortness of breath, hemoptysis, and fever. So her exam at that time, she had some wrist swelling and some elbow swelling. She had normal kidney function. Her urinalysis showed some blood. Interestingly, her rheumatoid factor and her CCP were negative. We don't have records from the prior rheumatologist, but she certainly didn't have any antibody evidence of rheumatoid at the time that we saw her, and she had markedly elevated inflammatory markers. Because of the hemoptysis, she had imaging, and I think even as a rheumatologist, I can tell you this isn't normal. So she has a large lung mass in the upper aspect of her left lower lobe, and you can see that it's kind of located against the posterior wall. And so she had a bronchoscopy that was done. She didn't have any evidence of hemorrhage. She had extensive infectious etiologies pursued that were negative. She had an endobronchial biopsy that showed acute and chronic inflammation. And so again, then finally her ANCA antibodies came back. She was positive at 1 to 640 with a PR3 of 30. and she was diagnosed also with GPA and treated with steroids and induction therapy, and she's doing quite well. She still is on a low amount of oxygen by nasal cannula because of some of the chronic injury that she suffered, but she's doing quite well now. So, what do we do for induction therapy now? Is Cytoxan as good as it gets for us? So, in 2010, the RAVE trial came out, and it was a randomized study that looked at comparing rituximab with cyclophosphamide therapy for induction therapy, and it compared 3 to 6 months of Cytoxan that was then transitioned over to azathioprine compared to a strategy of initial induction with rituximab. It's important to know that this trial excluded severely sick patients, so anyone with creatinine over 4, or anyone who had diffuse alveolar hemorrhage that required mechanical ventilation, because at that time it wasn't thought to be known whether rituximab would be safe, so they didn't feel comfortable assigning very sick patients to a potentially inferior treatment. The outcomes of that study was that rituximab was non-inferior. It was a non-inferiority study. And then cases of patients who had already had relapsing disease at the time of randomization, those individuals actually did better. So rituximab was superior to cyclophosphamide in that subgroup. And it's important to note that the results were maintained as far out as 12 and 18 months. These were patients that got a one-time treatment with rituximab. They didn't get serially retreated. So when they followed up at 18 months, again, you can see here, this is just pictorially describing what we saw before. The chance of relapse was the same between these two arms. And then when they subdivided according to PR3 and MPO status, not unsurprisingly, those with PR3 antibodies relapsed at a higher rate, but there was no difference between the arm that was assigned to cyclophosphamide followed by azathioprine and those that were assigned to rituximab. And so I think this was an important study because it showed us that there was an alternative that was at least as equally as good as inducing induction therapy for ANCA vasculitis. So at the same time, in that same issue of the New England Journal, there was a study called the Rituxavast trial. This was a European study in contrast to the RAVE trial, which was in America. And what's important about the Rituxavast trial is that it included individuals with extensive renal disease, which the RAVE trial excluded. So there was 44 patients in this study, so it's much smaller than the RAVE trial. But it did include people with severe renal disease. In fact, the median GFR was less than 30, and you had 20% of patients that were actually on hemodialysis at the time they were enrolled. This study looked at comparing what we consider traditional therapy, IV Cytoxan for 3 to 6 months, compared to a strategy of rituximab, but they also did give the rituximab arm 2 initial doses. So probably the way it should be viewed is they were studying whether you could use a much lighter regimen of IV Cytoxan along with rituximab and see if that was as effective as standard of care at that time. Again, the cyclophosphamide group was transitioned to AZA maintenance. This group that got rituximab, they didn't get anything afterwards, and rituximab's effects that we'll see later on last about 6 to 8 months. That becomes important in terms of the outcomes. Their primary outcome that they were looking at was remission at 12 months. And what you can see is that they essentially were equivalent between the Cytoxan and the rituximab arm. The secondary outcomes, which included things like serious adverse events, mortality, and the median increase in GFR were equivalent as well. Again, because these are such sick patients, you can see there's a high rate, 20% mortality at the end of 12 months. And so I think what this study tells me is that one, is very limited. There's only 44 patients, but that it might be an option in patients with advanced renal disease. But I think the jury's still out and more data needs to be accumulated. The RAVE trial looked at a subgroup analysis, and again, the RAVE trial doesn't allow us to make comments on patients with a creatinine greater than 4, but they did have a small number of people. You can see a total of 32 patients that had a baseline GFR less than 30 when they enrolled them in the trial, and at least in that subgroup, it appeared that there was no statistical difference between rituximab and cyclophosphamide for induction therapy. So I think there's growing evidence that it may be a viable option in patients with advanced renal disease, but we probably still need a little bit more data to feel totally comfortable in that population. Another case here. So this is a 57-year-old female who presented with 3 weeks of left greater than right lower extremity numbness and edema. He had a history of hepatitis C and cirrhosis. On exam, he had bruising in his bilateral lower extremities, although they weren't palpable on exam. His labs showed a rise in creatinine from 1.2 to 2.7, and this was over the last 6 weeks. He gets labs fairly frequently because of his history of cirrhosis, and he had urine with proteinuria and hematuria that was also new. He had complements checked that were normal, and he had a negative cryoglobulin evaluation. So prior to getting that cryoglobulin back, because that takes more than a week often, he actually had steroids started for a possible hep C-related renal disease, and he had a biopsy obtained. The day following his biopsy, his creatinine peaked at 4.94, and he was actually put on plasmapheresis. And his renal biopsy came back and showed a necrotizing crescentic GN in a skin biopsy that didn't show any signs of vasculitis. His ANCA antibody showed a p-ANCA positivity with MPO, and so he was diagnosed empirically with microscopic polyangiitis. And he was treated with steroids. He finished plasmapheresis and was given rituximab. So this is a patient who has advanced renal disease, and again, this is a kind of murky area in terms of the evidence, but after discussion with him, this is what he preferred in contrast to cyclophosphamide, and he did actually quite well. 2 weeks after his discharge, his creatinine was down to 1.84. 2 months after discharge, his creatinine was down to 1.1, and interestingly, only 2 months after rituximab, his p-ANCA antibody decreased in titer, and at 3 months out, I don't have it shown, but his ANCA antibody status was negative, and as was his MPO reactivity. So after we induce somebody with induction therapy, is that the end of everything? And it's really not, because what the RAVE trial showed us is that at 18 months, almost all those patients had reconstitution of their B cells. So rituximab clears B cells, binds to B cells and clears them. But when you give it, expectedly so, the effects are not permanent. And so in the RAVE trial, eventually 60% of individuals did relapse, and that relapse was really timed to when their B cells came back. So we know it's good at inducing remission, but it doesn't maintain remission forever. And so the question is, what do we do after we give someone induction therapy? And the standard of care to date really has been, as we point out in the earlier slides, azathioprine and methotrexate. But the question was, is that as good as it gets? Because relapse rates are still as high as 30% when you're maintained on these two regimens. And the thought would be, can we do better than that? So a trial that came out in 2014 was the main RITSAN study. It was a randomized controlled trial comparing azathioprine versus scheduled rituximab following cyclophosphamide induction. So all patients were induced with cyclophosphamide. Then they were maintained on either every 6-month infusions of rituximab versus getting azathioprine. There was 115 patients that were enrolled in total. The primary endpoint was major relapse at 28 months. And what you can see here is that there was a statistical and a clinically important difference between azathioprine and rituximab. So rituximab arm had 5% relapse, whereas the azathioprine arm had about 30% relapse. And so rituximab maintenance therapy was deemed to be beneficial. In terms of adverse events, so there was a similar rate of significant adverse events. There was a similar rate of severe infections. There was 2 deaths in the trial. They were both in the azathioprine arm. One was from pancreatitis, and one was from severe infection. So what have we learned from some of these trials in post hoc analysis? So I guess before we get to the post hoc analysis, there's been other studies that have looked at rituximab's effectiveness as well. So there's single center data from the Mayo Clinic as well as other institutions kind of describing their experience with using rituximab as a maintenance therapy. And similar to main RITSAN, the randomized trial, they showed similar benefit in a decreased rate of relapse with B cell depletion. In the Mayo Clinic experience, one thing of interest is that when they did have relapses, all the relapses occurred when the B cells reconstituted, meaning when the B cells came back up into a normal range, that's when a patient was at risk for relapse. In the RAVE trial, when they looked at who relapsed in that arm, only 1 out of the 24 patients who relapsed had undetectable B cells and negative antibodies. In other words, most of the people that relapsed had a recurrence or a return of their B cells or a return of their antibody status. And I think that's important because it's some preliminary evidence that if we see somebody without detectable B cells and without antibody reactivity, it makes it much less likely that they're going to relapse in the near future. There's an ongoing study that has just started, so Man-Ritson 2, which is undergoing way to find out, do we need to dose empirically every 6 months, or can we preemptively dose based on B-cell levels and ANCA antibody status? And so that trial is just underway to try to answer that question. So in summary, GPA and MPA share common treatment strategies, but they're unique entities. For GPA, it's associated with a higher rate of relapse. The PR3 antibody reactivity is associated with granulomatous manifestations, and it may suggest that that's a population that's more responsive to rituximab therapy. Biopsy does remain the gold standard, and again, that's because it's often important to rule out non-ANCA-associated vasculitic disease. If you see a concordant antibody and antigen specificities, that's the highest or the most specificity for ANCA-associated vasculitis. Induction therapy is usually uniformly required unless somebody has very limited sinus, ear, nose, throat disease. And then maintenance therapy allows us to use a less toxic med over time. Whether using repeated doses of rituximab will be safe, we don't know the answer to that. Probably about 25% of individuals that are given repeated cycles of rituximab, meaning more than 6 cycles, about 25% will have a decrease in their IgG level. And so, that's something that remains to be seen about what infectious complications are long term. And in most patients, this maintenance therapy usually means indefinite therapy. This is a study from the Cleveland Clinic that looked at rates of relapse-free remission in individuals who only maintain maintenance for 18 months versus those who maintain it for up to 3 years versus those who maintained it for more than 3 years. And so it's a rare patient, especially with PR3 antibody positivity. It's the rare patient who's able to get off of all drugs and have disease-free remission without medications. That's it. I'd like to just thank those in my division, Dr. Hollers, Dr. West, Dr. Hirsch, Dr. Jansen, all the people that have kind of worked with me throughout the years continue to be my mentors. And if you guys have any questions, I'd be glad to answer them.
Thanks, Jason. I think we might have some questions from the students and the house staff.
Thanks for the talk. That was fantastic. Just from a practical standpoint, I think when you're talking about induction, these are obviously some pretty heavy-hitting drugs with big side effects, and particularly Cytoxan, rituximab. But when we're talking about either like in the first case with kind of an acute decompensation from a respiratory standpoint or kind of severe disease and confirmatory testing that's going to take on the order of days or a week to come back, can you comment on just starting some sort of empiric treatment, whether that's just steroids and holding off on the other treatments?
Yeah, so, right away, the only thing that's probably going to be effective quickly anyway is the steroid component of the treatment. So, if you're using cyclophosphamide, it takes about 10 to 14 days to kind of hit the low point of immune suppression. And so, yeah, I think until a diagnosis is more confirmed, we'd be pretty reluctant to expose somebody to one of those medications. The risk of, let's say if you have a young female, the risk of affecting her ability to have children after one dose is pretty low, but at the same time, I think we'd want to wait until some of the confirmatory tests came in. And so things like steroids, potentially if you have a creatinine that's above a certain level, sometimes plasmapheresis could be considered. So there's things that you can do quickly while you're waiting for some of the confirmatory tests to come in.
Other questions? Rick?
Again, in the ICU, when you're dealing with acute hypoxic respiratory failure from alveolar hemorrhage, do you think there's a role for preferentially using rituximab over Cytoxan because of a more rapid onset of action with regard to B-cell depletion?
It's a good question. So I get everybody heard that. So the question is using rituximab preferentially because it leads to more rapid. Yeah, I think that in someone who's in that critically ill, again, I think most of the heavy lifting is probably being done by the steroid therapy that you're given and regardless. So I don't know that would influence me one way or the other. I do think we've used rituximab now anecdotally in patients who've been intubated, and I think similar to the renal disease the evidence on renal disease that you saw, I think we're going to get more and more experience with using it in advanced pulmonary disease in terms of rituximab. But I don't think I've chosen one over the other based on onset of action because, 2 weeks is probably about as fast as it's going to be for either of those agents. In fact, maximal B cell depletion with rituximab probably occurs more along the lines of 8 weeks in.
Jason, I was wondering if you could comment on the role of innate immunity in the progression of this disease, given the innate immunity in the progression of this disease, given the focality in the upper and lower respiratory tract, and also the small bit of evidence that treatment with trimethoprim sulfur in a chronic way might be helpful.
Sure. So I'll dodge part of the question. I'm not sure about the innate immunity part, but there's a lot of theories because of the involvement of the ear, nose, throat, and the lower GI tract portion that you're alluding to. There's a lot of concern that reaction to bacterial colonization in those areas may elicit an immune response. So in the context of renal involvement, there's antigen reactivity against a protein called the LAMPS2 protein, and that has kind of homology or molecular mimicry with gram-negative rods. And so, there's hypotheses that potentially because of colonization of bacteria in the lower GU tract, that you might develop an immune response that then would, cross over to a ANCA-related response. And the thought is that using Bactrim has been looked at, like as you alluded to, Bactrim has been looked at as a treatment. I don't think it's a very good treatment, but it does decrease risk of relapses, and it might do that because of some of its effect on bacteria.
Other questions? Okay, Jason, thank you very much. That was great.
Thanks.